Hi there. So it seems like in the medical field is the only time we can put a picture up like this and completely acceptable. So for educational purposes, I want to show you about benign prostatic hypertrophy and obstruction. So here's a picture of the male genital organ area, and I think it is important to show how the exam is done, because if you can see, and I'll make a little outline here around the prostate, as it's small, it looks like a little walnut actually, and so when we do an exam we can only really feel one side of it, but it does give us a good indication whether the prostate is hypertrophied, hence the benign prostatic hypertrophy. So one important thing, look at the urethra opening, and then you can see the urethra goes all the way up here. As you can see, the prostate really wraps around it. So imagine if the prostate is enlarged, how it squeezes on the urethra and can actually close off the urethra. So what ends up happening is urine ends up filling up in the bladder, and this patient has an obstruction because it can't go anywhere. If there's an obstruction and the urine can't go anywhere, then think about what can happen. So if urine is sitting in the bladder, it can become infected, and then it can go up the ureters into the kidney and cause pyelonephritis. So we're always looking for symptoms. So if somebody comes in and they have a urinary obstruction due to BPH, they're running a fever or have pain in the costovertebral angle, then that's something that you have to really look for. Maybe they have some pyelonephritis going on and including a UTI. So what are some causes of this? Well, aging is one cause that can cause obstruction to the area because the prostate then enlarges. There are some medications out there that we do put patients on to help shrink the prostate or increase or dilate the urethra, such as Flomax, to help the urine flow better. We try those medications first and just hope for the best, but if someone's prostate's really obstructed and really enlarged, then they have to go through what's called a TURP, transurethral resection of the prostate. So what they go ahead and do is they take a guide through the urethra here, and they actually resect the prostate. There's many, there's traditional resection, which has a lot of downtime. There's also a laser that they use, a holmium laser. There's a green light laser that they use. You don't have to know those, but just know that that is a method that they go in and resect it. That is less downtime. And they usually can go home fairly quickly after that. So once the prostate is resected, they will have a Foley catheter, and many times they will have the continuous bladder irrigation, or CBI, and watch the video on that. It's the 3-way catheter. The primary prevention of that is to prevent obstruction of the catheter after surgery, because remember, this prostate was enlarged, they just resected it, everything is swollen, so most likely the urethra is swollen, and they will be unable to urinate without a catheter in for at least a couple of days. So they keep the catheter in. We don't want any clots, so I'll erase this. We don't want any blood clots to form in the area here that it was resected, because then that will obstruct again. So we want to make sure we keep that continuous bladder irrigation going so that doesn't happen. Sometimes we have to end up irrigating it manually with a syringe. There's a video on that you have to watch, but most likely if you just keep the bladder irrigation open to keep that urine pink as possible, then that will significantly help. So if, let's say post-op day 1, it's normal for them to have more of a red drainage, but we want it lighter. So what are you going to do? You're going to say, oh, okay, well, maybe the continuous bladder irrigation is not going fast enough, therefore it's becoming more concentrated, more blood is collecting. We don't want a clot to form, so let's look at that and turn it up until it turns pink. If it doesn't go, if it doesn't run, and if you notice that no urine is coming out, then perhaps there is an obstruction or a blood clot in there. But it's very important to keep watching that. Usually the patient will end up going home with the catheter, and then they'll return to the urologist office. A couple days later, they remove the catheter and see if he can urinate on his own, and most of the time it's successful. Sometimes we have to end up putting the catheter back in, but usually that does not happen, and they do very well. I used to work in urology. To go back real quick to the beginning, most of these people with BPH, this obstruction comes on overnight or, kind of pretty suddenly. So you'll see these people come into the ER most often because they are unable to urinate and they start to feel uncomfortable. And that's it.